Oh, seizures and vitamin D. Did you hear that? Vitamin D and seizures? Hmm. Are they linked with one another? Well, I think vitamin D is related to seizures, or let me say vitamin D is the cause of the seizures. But wait. Before you think that Dr. Kazmi has gone nuts, let me clarify this thing that vitamin D is basically the acronym to remember the cause of seizures in children, and for that reason, not only in children but also in adults. So, welcome to my channel. Today, we would be discussing seizures in children A to Z. That means everything. And in particular, we would be focusing on the causes of seizures. We would be talking about the pathophysiology, the workup and diagnostics, and finally, we would be touching on the principles of management. So, without further ado, let's dive in and get started.
So this talk is going to focus on seizures. We will be discussing everything A to Z of seizures in children. And in particularly, we would be focusing on the causes, we would be focusing on the pathophysiology, the diagnostic and workups, and the principles of treatment. Let's start with the definition. So the definition, very simple definition of seizures is abnormal asynchronous excitatory neuronal discharge. What does that mean? Normally, the neurons in your brain are supposed to do different types of functions. So when we are thinking, when we are remembering something, when we are walking, we are talking, we are doing anything, so these are being controlled by the cells in our brain. And these brain cells, they are actually firing or getting excited in particular types of patterns, which are then responsible for the different things that we do. But sometimes these neurons can have a mind of their own, so they can start abnormally discharging. In other words, a group of neurons can simultaneously have excitatory discharges, bizarre patterns leading to different manifestations like abnormal jerky movements, different type of autonomic phenomena, or sometimes even psychological phenomena. So seizures are defined as abnormal asynchronous neuronal discharge, and convulsions is one of the motor manifestation of seizures. Now, earlier in a light mood, I said that vitamin D is the cause of seizures because vitamin D actually stands for the acronym to understand the different causes which are responsible for seizures. Now, there are so many reasons, so many causes which can lead to seizures that it becomes very difficult to remember each and everything. So, vitamin D is a very good acronym to group all these causes under certain categories, and it becomes very easy for you to remember or to know the different types of things that can lead to seizures. So, let's start with dissecting this vitamin D. The V of the vitamin D stands for vascular reasons. So many vascular reasons can cause seizures. If you look here in the left, so this is a rough diagram of the brain. So a vascular event like a vascular bleed inside the substance of the brain, which is known as an intracerebral bleed, can lead to abnormal asynchronous neuronal discharge leading to seizures. Uh, this can occur because of the irritation caused by the dead cells, which are actually irritating the surrounding healthy neurons and making them do abnormal discharges. Similarly, a bleed on the surface of the brain that could be in the form of a subarachnoid hemorrhage or could be in the form of subdural hematoma because of the rupture of the bridging veins can put pressure on the healthy neurons and cause them to fire abnormally, causing seizures. Similarly, sometimes uh, vascular bleeds on the top of brain, like outside the dura, which we call as extradural hematoma, which are usually associated with the tears of the middle meningeal artery caused by trauma, they can also cause pressure on the brain and cause seizures. Some of the other vascular regions which are not associated with bleeding but can cause seizures are increase in blood pressure. So when there is increase in blood pressure, what would happen is that some of the fluid inside the blood vessels would extravasate and would cause interstitial edema. This vasogenic edema in the posterior part of the brain, especially the occipital lobes, can cause seizures, and this is known as posterior reversible encephalopathy syndrome. So PRES or posterior reversible encephalopathy is nothing but it's vasogenic edema of the posterior part of the brain caused by increase in blood pressure. Similarly, if there is vasospasm of the blood vessels going to the brain, or there is thrombosis or any other reason, that would lead to less blood supply, or in other words, less oxygen supply to the brain. And these brain cells, when they don't get enough oxygen, they would go haywire, they would start asynchronous abnormal discharges leading to seizures. So these are some of the common vascular reasons responsible for causing seizures. Now coming to the I of the vitamin D, that is infections. Infections of the central nervous system. The central nervous system, is comprises of the brain and spinal cord, and it is surrounded by the layers which are known as meninges. So if there is a viral or bacterial infection of these meninges, which we call as meningitis, because of close proximity to the brain tissue, this inflammation can actually irritate the healthy neurons, causing them to fire abnormally, causing seizures. Similarly, if the infection there in the brain matter itself, so the neuron themselves get infected, it's usually caused by different types of viruses like herpes simplex virus, some other viruses, enteroviruses as well. So that can cause encephalitis, and encephalitis is actually inflammation of the brain, infection of the brain tissue itself, and it can cause seizures. In children, another big group which does not directly cause infection of the central nervous system but is responsible for causing seizures is what we call as febrile seizures. Febrile seizures can be caused by any febrile illness, be it a urinary tract infection, be it an upper respiratory tract infection, be it tonsillitis, be it pneumonia, be it other like simple common viral exanthems of childhood. This usually occurs in the age group 6 months to 6 years. And because of the rapid changes in the body temperature, somehow kids who are predisposed because of their genetic or environmental predispositions, the neurons, they go haywire, they start firing abnormally, causing seizures. But these seizures are usually short-lived. They are less than 15 minutes. They are usually generalized tonic-clonic, and nothing is wrong with the central nervous system. So, and this is quite common in kids between age 6 months to 6 years. We call them as febrile seizures. So this is another reason, infectious reason for causing seizures. Then the T of vitamin D stands for trauma. So trauma in the form of direct blow to the head causing skull fracture can cause impinging of the fractured skull bones directly into the brain tissue. And obviously that can lead to irritation, bleeds, or different other types of manifestations like contusion or concussion, and can lead to seizures. Sometimes there is no skull fracture, but similarly, because of the trauma, because of the sudden shaking movement of the brain, there might be tears at the axonal level, microscopic tears, or there might be frank like laceration inside the brain, which we call as contusion, while the microscopic shearing forces causing tearing of the axon is known as concussion. So both these can lead to seizures. So these are the traumatic causes of seizures. Then the A of vitamin D stands for autoimmune. Autoimmune conditions are those conditions in which, because of some reasons, the body starts producing antibody against its own cells. So these antibodies, they can attack different organs in the body. They can attack joints, they can attack liver, they can attack kidneys. Similarly, in certain autoimmune conditions, these antibodies can go and can attack the brain cells. And one particular condition which is worth mentioning is SLE, systemic lupus erythematosus, which has got a criteria for diagnosis. But usually they've got like photosensitive rashes on the face, they've got joint problems, they can have like inflammation of the serous membranes, and they can present with neuropsychiatric phenomena, sometimes even seizures caused by these antibodies attacking the brain cells. The M of the vitamin D stands for metabolic reason. Again, this is a big group. This includes different types of metabolic disorders. Some of them are enzymatic in nature, like phenylketonuria, tyrosinemia, etc., etc. But for by and large, most of the time, by metabolic reasons, we mean like when there is abnormal quantities of different elements or nutrients in the body. Especially worth mentioning is decrease in glucose. So glucose or hypoglycemia is one of the most common metabolic reasons of seizures. It can occur because of starvation. It can occur because of overdose of insulin. It can happen even in diabetic kids who have taken insulin but haven't taken something to eat. So hypoglycemia is one of the very common metabolic reasons for causing seizures. Then problems with the sodium, either increase or low sodium, more so the decrease in sodium, hyponatremia can cause seizures. Similarly, the low levels of magnesium and calcium can also predispose to seizures, and then kids can have seizures. Then the metabolic organs themselves, like if they have got like abnormal functioning, like an increase in thyroid hormone production, hypothyroidism leading to thyroid storm, that can also cause seizures. Similarly, problems with liver and problems with kidneys, obviously, they can lead to metabolic derangements, and later on that can cause increase in certain toxic metabolites which can cause seizures. Like for example, if liver is not properly functioned, that will lead to an increase in ammonia, and ammonia is responsible for causing seizures and depression of the central nervous system as well. Similarly, if kidneys are not properly working, that would lead to increase in urea, which we call as uremia, and that can also be responsible for seizures. So these are some of the metabolic reasons responsible for causing seizures. Okay, coming down to the I stands for the idiopathic reasons. And idiopathic reasons are those when we don't find any reasons, we call them idiopathic. And there might be certain genetic and environmental predispositions which can cause idiopathic, or when the cause is not known. Most of the epilepsy syndromes of childhood, they fall within this category because there might be a genetic predisposition, but there is nothing structurally wrong with the brain cells themselves. So juvenile myoclonic epilepsy, uh, benign Rolandic epilepsy of childhood, these are some of the epilepsy syndromes of childhood. Then the N of the vitamin D stands for neoplastic. So neoplastic means neoplasms or abnormal growth. So some of the abnormal growths which can occur in the brain, like the abnormal growth of glial tissue, which is known as glioblastoma, that can cause like pressure and obviously destruction of the adjacent healthy neuronal tissue, apart from, along with edema and other things, which and combination of all these factors that can cause seizures within that area. And similarly, meningioma, which is a benign tumor, but because of its pressure effects directly on the top of the healthy brain tissue, that can also lead to abnormal discharge from the neurons, leading to seizures. Then the D of vitamin D stands for drugs. Many types of drugs can cause seizures. And from clinical point of view, especially in adolescents who are sometimes brought by paramedics, they were absolutely fine, or they were found in the park unconscious and then suddenly started having seizures, you should be thinking of the drugs. So some of the drugs that, especially the stimulants or the recreational drugs that can cause seizures are cocaine, stimulants like amphetamine or dexamphetamine. Similarly, overdose of tricyclic antidepressant can also cause seizures, and opiates can also cause seizures. Similarly, some of the other reasons which can cause seizures is like that's usually more common in adults, like those who are alcoholics and they're suddenly alcohol withdrawal. Usually, that can also, like vernix encephalopathy, they can have seizures, and sometimes deficiency of vitamin B1 thiamine that can also lead to seizures. But more so common, like in children, from drugs point of view, are usually either deliberate overdoses of tricyclic antidepressants, which are usually done for self-harm, or recreational drug use, like use of cocaine and vitamins, that can cause seizures. So usually if the kids, like, as adolescents who are coming in with seizures at this age group, the history is not very clear, urine toxicology is mandatory in those cases to find out. They might find out certain those drugs which are responsible for causing seizures. So this in a nutshell is vitamin D, which is the acronym for remembering the cause of seizures in children. So once again, quickly: V for vascular, I for infections, T for trauma, A for autoimmune, M for metabolic, the other I for idiopathic, N for neoplastic, and D for drugs. This is how you should be remembering the causes of seizures in childhood. Moving on to the pathophysiology. The brain is composed of millions and billions of neurons which are connected with one another. So the structure of neuron you can see over here. So it has got a body along with the dendrites, by which it, like, makes synaptic connections with other neurons, and then it's got long, like sheath-like structure, long tail-like structure, which is known as the axon. And at the end of axon, then it actually attaches with another neuron. So uh, whenever the one neuron attaches with the other neuron, there are two types of receptors on the surface of the neurons. One are known as the excitatory receptors, and the other are known as inhibitory receptors. Very simple: excitatory and inhibitory. Excitatory receptors, they are actually acted upon by the excitatory neurotransmitters, and the common excitatory neurotransmitters in brain are glutamate and acetylcholine. These two are excitatory neurons. So whenever these glutamate or acetylcholine is released by the presynaptic vesicles at the neuronal junctions, so they would excite these receptors, they would open, and when these are open, what happens? The positive ions would go inside. So sodium and calcium would go inside. So when it goes inside the cell, what would happen? The positive charges inside the cell would build up, and it would reach a threshold where the positive charges would open up the voltage gated channels along the pathway of the axon, and that would lead to the propagation of electrical impulse down this um, axon, which we call as action potential. And that action potential would reach another neuron, excite that, and this way the action potential is simply the neuronal impulses they propagate within the brain tissue. If from the presynaptic vesicles, the inhibitory neurotransmitter GABA, which stands for gamma aminobutyric acid, if that is released, it would actually bind with the inhibitory receptors. Now the inhibitory receptors, when they get open, what would happen? The negative ions would go inside. So the chloride ions would move inside. As the chloride ions move inside, there would be more negative ions inside, more negative charges inside the neuron, and it becomes very difficult to excite. So the impulse would stop there, and then whenever an inhibitory channel opens up and there is a buildup of negative charges inside the neuron. So either an increase, remember, either an increase in the excitatory neurotransmitters or their action on their receptors, or a decrease in the activity of the inhibitory neurotransmitters. Both of them would lead to more chances of abnormal impulses traveling down the neurons. So either an increase in glutamine and acetylcholine receptor activity, or a decrease in the inhibitory receptor activity, both would lead to the same effect. Both would lead to generation of abnormal impulses, and that's how an abnormal impulse, once generated, can propagate down number of neurons, leading to seizures. Now again, this is the basic pathophysiology. Now the number of cells that are generating these impulses, they can either be limited to one part of the brain. So let's say many neurons in a one particular area, they get excited, the impulses are propagating, but at a particular part they just die down. So there is only this abnormal excitation within a confined anatomical place. We call it as focal seizures. So focal seizure is abnormal excitatory neuronal activity within a confined anatomical zone inside the brain. So it can be in the cortex, it can be in the temporal lobe, it can be anywhere, but it is limited. It does not cross to the opposite side. So what would happen when there would be abnormal excitation in this area? So the body parts which are represented in this area of the brain, they would exhibit abnormal jerky movements. So these children can have like focal seizures, so like sudden jerky movement of one arm like this, or one leg. Sometimes these focal seizures can generalize as well. So rarely, if they are close to like pathways which cross over, then the impulses, focal impulses, can generate and can cross to the other side. We call it focal seizures with generalization, secondary generalizations. Though rare, but it can happen. Also keep it in mind that focal discharge, abnormal discharge of neurons, if it happens for a period of time, then what would happen? After some time, these neurons, they would eventually they get exhausted. When they get exhausted, because there is depletion of all these vesicles of neurotransmitters and things, so even if they have now to generate impulses, it's not easy. So in other words, they are quite tired for a considerable period of time. So that part of the body which was jerking earlier, now it cannot make any movements. So it would be sort of paralyzed. We call it as Todd's paralysis. So Todd's paralysis is nothing but it is a sort of a pseudo paralysis caused by depletion of the neurotransmitters in those neurons which were earlier firing abnormally. And this usually happens in focal seizures. So focal seizures, jerky movement followed by paralysis in that part, which is known as Todd's paralysis. if these abnormal excitatory neurons are in that area, which is in the center of the brain or where the pathways are crossing or accusating to either side, then the neuronal impulses would be going in all the directions. So it would like spread to all of the brain. We call it as generalized seizures, or more commonly caused by metabolic reasons, those reasons which are present in the blood because the same blood is going everywhere, or because of the accumulation of toxins, because of liver failure, kidney failure, or any other reasons, or because of the accumulation of drugs. What would happen? Because all of the whole of brain is involved. So what would happen? That the impulses would be traveling down in all directions. We call them as generalized seizures. So generalized seizures mean that the neuronal activity is crossing the opposite lobe and is spreading to different parts of the brain. It can manifest in different forms clinically. It can manifest in the form of tonic seizures. So tonic seizure would be sudden increase in tone. You know, whenever tone is increased, you know, by your knowledge of neurology, that there is upper motor neuron involvement. So if the upper motor neurons bilaterally are involved and the impulses are not traveling down, so what would happen? They have spread, but they are confined to both areas of the cortex. So there will be increase in the tone. So the body would become stiff. It might be closely followed by then clonic seizures. Then again, as the waves they propagate down and other areas they also get affected, so that would lead to repetitive jerky movements because the same impulses are like reverberating. It's a circular movement. One neuron getting excited, exciting the other one, and the impulse is coming back again, exciting the same one. So you got this repetitive jerky movement. So tonic means stiffness followed by clonic means jerky movement. So tonic seizures and tonic clonic seizures are manifestation of general seizure. Similarly, you can have myoclonic seizures. The myoclonic seizures are sudden, like violent, jerky movements of the body. Again, it's common in infants. It's form of generalized seizures. Similarly, absence seizures. So absence seizures are also generalized seizures. The only thing is that in here, the motor cortex is not involved. It's basically the reticulocortical pathways which get switched off because there is abnormal excitation in the surrounding neurons inhibiting these one in turn. So what happens is that sort of a link between the subconscious and the conscious level is broken off temporarily for a few seconds, which actually manifests clinically in the form of dissociation. So a child is totally disconnected from the reality. He's blankly staring. He doesn't know where he is and then suddenly comes back. So that is absence seizure. So it's also a form of generalized seizure. Or sometimes if the abnormal excitatory activity is happening in, let's say, in the deeper parts of the brain, like the cingula, the putamen, the globus pallidus, then it can lead to autonomic features or automatisms. So automatisms are very strange movements. They are not in the control of the body, and young children can present with very strange phenomena, like for example they can have smacking lip movements. They can do like this, or they can say have sudden blinking of the eyes, so they can blink like this, or they can sudden, like, turn to one side and looking towards one direction. So or in very small babies, we also call them subtle seizures because very difficult to put, like cyclic movements of the body, paddling movements, swimming movements. These are actually manifestations, automatisms. And sometimes in older children, like those who are going to school, Peniotopoulos syndrome, which is actually an autonomic seizure, is caused by uh, problems in the occipital lobe. So a child who's sleeping suddenly wakes up, throws up, does vomiting, and then becomes unresponsive for some time. He has got paler, increase in heart rate, and then he comes back. He hasn't got any jerky movement. So that is also a form of autonomic manifestation of seizures. So for all the reasons that we discussed, vascular infections or drugs or neoplasms, they can present either as a focal one, they can present as a generalized, or they can present as autonomic manifestation of seizures that can then lead to different forms of clinical manifestation. Again, I told you clinical manifestation could be in the form of focal symptomatology, focal jerky movements. It could be in the form of psychological phenomena, especially focal, when the temporal lobes are affected, like, for example, hearing strange voices, seeing strange things, strange smells. We call them deja vu phenomena. Similarly, the generalized, as I said, tonic seizures, tonic-clonic seizures, myoclonic seizures, and then autonomic in the form of automatisms. Especially, this is more common in neonates and very small babies. Moving on to the workup and diagnosis. Now, I told you by and large the most common cause of seizure in children are febrile seizures. So anyone who comes with a seizure or a history of seizure, the first thing to ask is if they've got a fever. So if they've got a fever and they are within that age bracket, 6 months to 6 years, you should be thinking of febrile seizures. So for febrile seizures, it's very simple. Like the thing is, you have to control the fever and you have to find the focus of infection and treat that. So if it is tonsillitis, treat it. If it is URI, treat it. If it is UTI, treat it. Else, if you don't find a focus of infection, then you might have to hunt a bit more. Like you might have to do blood cultures, you might have to do urinalysis or urine culture and sensitivity. You might have to look at the chemistry, full blood count, or if the age is less than 6 months, or if you think there have been complex febrile seizures or the seizures were like prolonged and there is a prolonged postictal phase, and you think that there might be a possibility of meningitis or encephalitis because there is an acrid or there are pyrrhic spots, then in that case you should do CT scan and followed by lumbar puncture to see if it is meningitis, viral or bacterial, things like that. If somebody who comes with a history of having epilepsy and already on anti-epileptic drugs, he might be seizure free, or he might be having seizure, but suddenly the intensity or the frequency of seizures that increase, then those who are already on anti-epileptic medication, it's very important to check their anticonvulsant levels if those tests are available. So if somebody is on phenytoin, you can check the phenytoin level. If somebody on valproate, you can check the valproate levels. So why do we check it? Because we have to see the compliance. Most of the anticonvulsant medications have to be adjusted according to their body weights, and the dose has to be increased if their weight is increasing. So it's important to look at the anticonvulsant levels, because if they are not having good compliance, then they can have breakthrough seizures. So when you look at the anticonvulsant levels, you might find that the anticonvulsant levels are within that range that is considered as a normal range. So if it is within that, you still might have some, sort of some level of playing around. So for example, if it is in the middle, you still have got some uh, yeah, like some liberty to increase the dose. So let's say you can increase the dose, or if it is already at the lower end of the normal, then you can increase it further, or if it is already at the maximum dose, then probably you can start another anti-epileptic medication. Similarly, for those who have got the first time seizure, who are coming up with seizure for the first time, again, it is very important to take a thorough history and physical examination to rule out what we call as vitamin D. So all those causes, they need to be to see whether it's a vascular infection, neoplasm, idiopathic, whatever. So you have to take a very thorough history and a very thorough physical examination to find out the reason. You might also look for any syndromic associations which might point towards like specific syndromes like Rett syndrome or metachromatic leukodystrophies or Zellweger syndrome, so on and so forth. Now, if they've got a history of seizure, they are not seizing in front of you. History and physical examination is absolutely fine, and the child himself is also absolutely fine at the time of presentation. He's playing around. All his vitals are normal. Then at the same time, it's also very important to rule out seizure mimics, because what parents might have thought as seizure might not be seizure. There are certain things which are more common than seizures. They mimic very much the seizures, and it's important to rule them out, especially if the child is absolutely fine. The first of them is what we call as breath holding spells. So breath holding spells very common in small children, kids who have got like temper tantrums, who would cry because one reason or the other. Finally, because of excessive crying, they would stop breathing for a while. When they stop breathing, the oxygen levels go down, the neurons go haywire, and they can have some abnormal discharges for a few seconds to a few minutes. And obviously, that is a seizure-like activity, but in fact, it's not seizures. We call it breath holding spells. Most of the times, they would pass out, but sometimes they can have seizures as well. Reflex anoxic seizures is related to breath holding spell. The only thing, and this is a child is not crying. So usually with trauma or with severe like sudden excitation, what happens is that the child suddenly goes pale, and they just like drop dead. And there might be what happens, they usually like they stop breathing for a while, and that again leads to the same manifestation, low oxygen, leading to temporary seizures, but they come back. So that is known as reflex anoxic seizures, usually common after trauma or after pain or sometimes sudden excitation as well. Another thing that can mimic seizures is gastroesophageal reflux. So small babies who got reflux, sometimes they might arch their backs and turn their neck to one side, which actually mimics like a tonic seizure, but it is actually caused by the pain due to gastroesophageal reflux. We call it as Sandifer syndrome. So Sandifer syndrome can mimic seizure. Then vasovagal syncope, which is again common in older children, kids who are standing for a prolonged period of time, or who are, playing in hot ambience, or those who suddenly wake up early in the morning and then go to the toilet and suddenly they fall down, they drop dead, and they pass out, and then they can have a few seconds or minutes of seizures. We call it vasovagal syncope. It's because of the sudden instant vagal stimulation caused by different things, leading to bradycardia, reduced cardiac output, and that leads to seizure. Similarly, kids who are playing and suddenly they pass out and have seizures, especially doing diving or strenuous exercises, you should always rule out heart problems, especially channelopathies like long QT syndrome. So ECG is mandatory in all these things. Or some kids who have got hypertrophic obstructive cardiomyopathy, they usually present with chest pain, palpitations, they can pass out and they can have seizures as well. So if somebody's got chest pains with that, again, take it seriously and do ECG. And well, if you think that there might be a chance of hypertrophic obstructive cardiomyopathy, or there has been a history of like cardiac death at a young age, then they need to undergo echocardiography as well. And in certain cases, more so common in girls, pseudo seizures in which they've got like bizarre uh, movements of the body, pelvic thrusting. It is one form of conversion disorders, and usually they've got like psychiatric issues associated with them, so they can present with all those bizarre seizures in which there is no incontinence. They are forcefully closing their eyes, and it's very bizarre, like strange form of jerky, thrusty movements, which we call it pseudo seizures. So again, that can mimic and can be a reason of great parental anxiety, but again, they are not seizures. So for all those kids who are normal and you have ruled out the pseudo seizures, then what to do with them? I mean, remember, one seizure does not warrant starting anti-epileptic medications. So they have to be followed up in the neurology clinic. If they have got further seizures, or you think they're fitting in the definition of epilepsy, then they need to undergo EEG, because we need to find out if there is any EEG pattern which might be pointing towards a specific reason, because sometimes some form of seizures have got their own very characteristic EEG findings, or that can simply confirm those types of diagnosis. So they have to undergo an EEG. Again, these days we mostly do video EEG, but sometimes we can also do the augmented EEG as well. Anyhow, I will cover EEG and their patterns in another lecture, because if I start talking about the EEGs and the patterns and how they look like, what is a polyspike pattern, what's hypsarrhythmia, and what is three cycles per minute, these types of things, then obviously it will take a lot of time. Moving on to the treatment. Now, the principle of treatment depends on the underlying cause. So if a child is having febrile seizures and he's got tonsillitis, you have to treat tonsillitis. If he's having UTI, you have to treat UTI. Similarly goes for all those things. If somebody having a vascular phenomena, you have to treat that. Somebody's got a neoplasm, you have to remove the neoplasm. So very simple. Treatment of seizures is treatment of the underlying cause that is causing seizures. So you go through your vitamin D drill and just find out the reason and treat that. Well, for idiopathic, or where you think of epilepsy, or there are certain syndromes, or let's say you have done an EEG and you have diagnosed, let's say, West syndrome or any form of epilepsy syndromes, then you have to start then on anti-epileptic drugs or anti-epileptic medications, as we call them. Now, the principles of anti-epileptic medication. Now, remember, there are different types of anti-epileptic medications. There are the first generation medications which are still very effective, and we still use them. Then we've got the second generation, the third generation medication as well, which are given, which are expensive, but that can be started in certain circumstances. And then there are certain adjuvant drugs which can be added on if one or two drugs are not controlling the seizures. That usually happens in refractory seizures. So refractory seizures are basically when you have tried two types of anti-epileptic drugs on their maximum dosages, and still the child is having seizure and is not seizure free. So we call it refractory seizure. For that, then we can add, add on certain adjunct drugs. Anyhow, So for any medication, whether you start the child on carbamazepine for focal seizure or whether you start them on valproic acid, you always start with the lowest dose possible. So you start with the lowest dose and then you have to adjust. You never start with the full dose. You have to increase it incrementally. So over the next few days or every week, the dose has to be adjusted till you reach that stage where the child is seizure free. So usually most of these drugs have got a range. So it's not necessarily that you have to go to the maximum. You will just stop where the child is seizure free and you will maintain that dosage for the next 2 years. You have to ensure that the child is on anti-epileptic medications and is seizure free for 2 years, for full 2 years before you can start thinking of weaning them off. This is very important. And again, because a long-term treatment, you always start with a low dose and you would adjust them with a period of time, like every few days to every week, you have to adjust the dosage. And you sometimes the child might not be seizure free even despite reaching the maximum dose of one drug. So monotherapy is recommended, but sometimes monotherapy might not work because of complex underlying reasons. So once you have reached the maximum dosage of one drug and it's not working, then it's time to start a new drug. So a second drug has to be started. And then again, you will start with the same principle. You start with the lowest dose and you gradually build up. Now, the drugs of choice for tonic-clonic seizures, because of various reasons, still the drug of choice is sodium valproate. So sodium valproate can be started in a dose of 10 milligram per kg body weight, and you can increase it up to 40 milligram per kg body weight, and it's usually given twice to thrice daily. You have to divide the dosages, but we always start with 10 milligram per kg body weight and slowly and gradually we build it up. Similarly, for focal seizures, we use carbamazepine. Remember, carbamazepine is not recommended for generalized tonic-clonic seizures or for, let's say, juvenile myoclonic epilepsy, because it can simply aggravate the seizure. So the NICE guidelines, they actually recommend against using carbamazepine for for generalized seizures. So that's why its use is now limited to focal seizures. For absence seizures, ethosuximide is still the drug of choice. Sometimes if ethosuximide is not, lamotrigine is the alternative. And then for infantile spasm, which is a specific type of illness which can lead to West syndrome, that actually is worth mentioning, because in that the only anti-epileptic medication we use is ACTH, so adrenocorticotropic hormone, or if it is associated with tuberous sclerosis, then we have to use vigabatrin as well. So this is a different condition in which different medications are used. We also have got newer drugs like levetiracetam, zonisamide, or rufinamide, which is used for Lennox-Gastaut syndrome. Again, they can be used, but I mean, personally, I would leave it to the pediatric neurologist to decide on these newer medications, because they are more expensive, they are associated with more side effects, and obviously they need to be closely monitored when you have to prescribe these medications. And as I told you earlier, a child has to be seizure free for at least 2 years before you start thinking of tapering off the anti-seizure medication. And remember, if a child is not seizure free even after maximum dosages of 2 anti-epileptic drugs, we call it refractory epilepsy. And for refractory epilepsy, then we have to use adjunct drugs. So like adjunct drugs could be clobazam, it could be even some form of stereotactic surgery or ketogenic diets, they can be tried. But anyhow, that is beyond the scope of my today's lecture. Moving on to one thing more, which is also worth mentioning, is that so far we have talked about seizures, and in most of these cases, a child has had seizure or seizure-like activity at home. He is brought at the time of examination or at the time of presentation, he is fine. But what if you are seeing a patient and he starts having fits for one reason or the other reason? If a child starts having fits in front of you, what would you do? It might be that a child is absolutely fine, but for some reason he starts having fits, either because the blood glucose level goes down or he's got an underlying condition and suddenly the covert things become overt or whatsoever. Or he's having fits, he had a fit and he was fine, but now at presentation he starts fitting again. So whether he has got an ongoing fits or whether he starts having fit in front of you, what you do, the first thing is you start the clock and then you start to straight away go to your ABC. So the very first thing is that After starting the clock, you would open up the airways. So opening up the airways doesn't mean that you need to put an let's say a nasal what you call an oropharyngeal tube or something like that. You can simply do your simple maneuvers, airway opening maneuvers like head tilt and chin lift or jaw thrusting. So that, like, just takes the pressure off the airways and they open up. Then the next thing is, because the child is fitting, that is a hypermetabolic state. So straight away you would attach them to the oxygen. So you should start them on 100% oxygen, 15 liters per minute through a non-rebreathable mask, and then attach to the monitors to monitor the O2 sats, because obviously if you don't get the oxygen if the child is fitting, the sats will drop. You also check the circulation. So by circulation I mean you look at the capillary refill time, you look at the blood pressure, you look at the heart rate, and at this time you should also try to cannulate the child and get an IV access. And at the same time, a quick finger prick blood glucose test is very important, because that could give you the blood glucose levels. In case if the blood glucose levels are low, it's very simple to treat them. You can give them 10% dextrose, like 2 mils per kg, and that would like just stop the seizures quickly. So you have already started the clock. You open the airways by simple maneuvers like head tilt, chin lift, or jaw thrust. You have started the child on oxygen. Uh, you have got an IV access, or even if you haven't got an IV access, at least you have taken the pulse, the heart rate, and the cap refill time, or the blood pressure. So by the time the 5 minutes are over, you see if the child has stopped seizing by 5 minutes, what you will do, you will simply monitor the child and see what was the reason for that fit. If the child is still having seizures at 5 minutes, what you do is, now at this point in time, you have to give them benzodiazepine. So again, it depends whether you've got the IV access or not. So if you've got the IV access, you would give them lorazepam intravenously. The dose is 0.1 milligram per kg body weight to a maximum of 4 milligram. If you haven't got the IV access, then you can also take an intraosseous drill, and you can just drill it in the tibia, and you can give an intraosseous lorazepam as well. Or if you are not comfortable with the intraosseous drill or something, then you have got the choice of giving them buccal midazolam or rectal diazepam as well. So buccal midazolam and rectal diazepam, they've got the same doses, 0.5 milligram per kg body weight. So at 5 minutes, as I told you, if they're still seizing, IV lorazepam or buccal midazolam or rectal diazepam, you give it, and now you wait for 10 minutes. So within 10 minutes, if this medication has stopped the seizure, well and good. You further continue and find out what had caused seizures. If they're still having seizures at the end of 10 minutes, you will just repeat this procedure. So you repeat step one. It's the same thing. Whatever you have done in step one, 0.1 milligram per kg body weight lorazepam or buccal midazolam or rectal diazepam in a dose of 0.5 milligram per kg body weight, this would be repeated. And you will again wait for 10 minutes. Again wait for 10 minutes. So after the second 10 minutes, if the seizure stops, again you will monitor. If it's not stopping, what you can do, you have to prepare phenytoin infusion or phenobarb infusion. It depends. If the child is already taking phenytoin, then you can't give them phenytoin infusion. You have to put him on phenobarb. But let's say if the child is not on phenobarb, then sorry, not on phenytoin, that you have to you can give him phenytoin infusion. And while you are preparing, or the nurses are preparing the infusion, a quick thing that can be given rectally is paraldehyde. So 0.8 mils per kg body weight, and you mix it 1:1 ratio with oil. Rectally can be given. Sometimes it is also effective in stopping the seizure. But let's say if this is an optional step, if you don't do it, no worries. Straight away you prepare the phenytoin or the phenobarb infusion, and again the dose is the same, 20 milligram per kg body weight, and it has to be given over 20 minutes. So remember 20 and 20. So 20 milligram per kg over 20 minutes. Again, you have to wait for this 20 minutes. After this 20 minutes, if the seizures are stopped, again, you would monitor them. But if the seizures are continuing, now you need expert opinion. So you need to involve the anesthetist, because this child might need thiopental and general anesthesia to stop the seizure. And obviously, when they would need general anesthesia, they need to be intubated. Or they might need continuous phenytoin infusion. Again, that decision has to be taken by experts. So you have to involve, by this time anesthetist has to be involved. Most of the times it would be terminated at step 1 or step 2 or maximum at step 3 when you start them phenytoin. But obviously if somebody goes to step 4, then they have to be intubated. You might have to do a CT scan, you might have to do a lumbar puncture, you might have to think about cerebral edema and so many other things to see what's going on, and then you have to manage accordingly. So this was the management of status epilepticus or a seizing child according to UK research guidelines. This is what we use here in UK, and this is very effective, and you should remember it on fingertips, especially those who are working in pediatric emergency medicine. They should be very familiar with this drill, and you should be very good at this thing. So in this lecture, we discussed the causes of seizures in children. We talked about the pathophysiology. We talked about the workup and diagnostics, and we also talked about the principles of anti-epileptic medication with special emphasis on treatment of status epilepticus or treatment of a seizing child according to UK research guidelines. So if you have liked this video, now do press the like button, and if so far you haven't subscribed to my channel, so do subscribe. And if you want me to prepare or videos or lectures on some special topics, you can put down your request in the comment section below. Even if you've got any question, you can put down in the comment section below, and I will try my level best to address those things. So I'm signing off. Have a good day. Bye bye.